Hello, everyone, and welcome back to another of our Meet the Expert series, where I get to pick the brains of my very intelligent friends and colleagues. Today, we have Carina Siracusa joining us, and I'm delighted. We met in Italy at the ICS conference last year. Yes,
Yeah.
It's all a blur. We met in Florence. And we've been communicating online. I'm delighted to say that Carina will actually be coming to Ireland to teach next month. We're delighted to be having her. But I run a group for clinicians called Global Pelvic Physio, and in that group questions come up every so often about neurological patients, whether it's stroke or MS or spinal cord injuries. This is not an area that I have a lot of knowledge in, so I always find myself tagging Carina in these questions and then kind of sitting back and being amazed and going, oh, I never thought of that, because she just answers them so easily. So I thought she would be the perfect person to get on and have a chat about this. But before we jump in and get super nerdy, Carina, do you want to just introduce yourself, tell us about where you are and how you got to where you are today?
Sure. So I am a physiotherapist in Columbus, Ohio, which is right in the Midwest of the United States. I've been in Ohio my whole life, so that's where my Midwestern accent comes from. I actually started my physiotherapy career as a pediatric physio, just doing developmental peds. And what happened was the hospital that I worked for at the time had asked if there was anybody interested in taking some pelvic floor courses, and I thought, well, this will be a nice way to save my back a little from being on the floor all the time. Yep. So I took some classes and really fell in love with pelvic floor and treating women and men with pelvic floor issues. And as I continued to treat pelvic floor and peds, what I saw was this really, everything I was learning was really applying to the neurologic population. When I say I treated peds, I was in a very small town, rural area. So I treated people with neurologic difficulties from essentially birth through adulthood, because people with cerebral palsy and spinal cord injuries were coming back in for therapy, and nobody else really felt comfortable treating those in the clinic that I was in. So that's where some of my interest in the neuro population came from. And now I treat strictly pelvic floor. I still treat pediatrics from a pelvic floor perspective, but I no longer do developmental peds or traditional neurophysiotherapy. I work for a hospital system called Ohio Health in Ohio, and I, along with two other people, are the main physiotherapists for the neuro population. So we have a very large neurologic center, and I work very closely with the neurophysiotherapists to see all of their patients for their bowel and bladder concerns. So this is a huge passion for me because I feel like it is a missed population. I feel like we are not doing enough for patients with neurologic concerns. And I also, in talking to other pelvic floor physios, I do feel like a lot of people get nervous around this population.
Yes.
They feel like they don't really, know what to offer. Somebody comes in a wheelchair and they can't get up onto an exam table, and they kind of don't know what to do with them. They think, I can't treat their pelvic floor. They can't get up there. So I really am passionate about educating people and trying to provide that education that even if you don't get them out of their wheelchair, there's something we can do for them.
I think that's a really important point, Carina, because I think I would imagine that a lot of the neuro PTs are scared of the pelvic floor, and the pelvic health PTs are scared of the neuro issues.
Yes.
So a lot of these patients end up falling through the cracks, and not getting their needs met. And I suppose, particularly after a catastrophic event like a stroke or with a diagnosis like MS, maybe bowel and bladder health aren't first and foremost on the radar, but in terms of quality of life, I would imagine these are absolutely huge issues for these patients.
Yeah, it is. It's really interesting, actually, because a lot of people think it is the loss of mobility that people are most concerned with. But if you look at the quality of life research studies, especially with patients with spinal cord injuries, the loss of bowel and bladder rates higher than the loss of mobility.
Wow.
So people care less about the fact that they are in a wheelchair and they have that loss of verticality than they do that they, no longer have control over their bowel and bladder. And there are so so many things that we can do to help these clients, get back that portion of their life. I am always amazed when I treat, especially patients that have had a traumatic spinal cord injury, for instance. I end up seeing them because I've educated their neurotherapists, and they've become advocates for the importance of bowel and bladder. And they haven't seen a urologist. They haven't had anybody address their bowel program since they were an inpatient. And, they're now 6 months out from their initial neurologic insult, and they're not catheterizing properly, or they don't know what their bowel program is. They're constantly constipated. The constipation that I see in these patients, and I can't tell you how many times I've seen them once or twice, and they come back in and they say it's gone. It's better.
Change their lives. Yeah.
Yeah. And then what happens is that they can better focus on their neurologic recovery, because they're not dealing with this in the background. If you think about, if anybody has ever been constipated, the last thing you want to do is go, practice walking or do strength training or any of the
motor skill.
Exactly. That's all you can focus on, because that's all you can feel. And so the neurotherapists that I work with find the pelvic floor things that I do invaluable, because they say they have better outcomes simply because I'm a part of that team.
Absolutely. Well, I remember, years ago, reading and then hearing about Mary Massery's work, and how she really changed my perspective on, on the role of the diaphragm and the glottis and pelvic health and central stability. And again, coming from that maybe pediatric neuro background like yourself, I'm very excited to be going to her course in Cork next month. But I really think that if you haven't got that central stability or control, first of all, that's going to be huge, as you said, in terms of just basic functionality. But if you're worried about leaking, either from the bladder or the bowel, that's a huge distraction. But I would imagine as well, because, what we're learning more and more is that, our brain function is so tied to our gut function as well, just even in terms of serotonin production, happening in the gut and the availability of that. And then just from a motivation point of view. So where do you start?
Yeah, so that's the question I get from a lot of therapists. Where do I start? I'm so nervous about treating this population. And so, what I often tell people is, as a pelvic floor physio, you have most of the knowledge to treat this population. It's adding in that neuro piece.
Okay.
And so, what I highly recommend any pelvic floor physio that is thinking about treating this population is to start reading some articles that are maybe not necessarily about the pelvic floor, but about that neuro population, or go shadow with a neurotherapist and talk to them about what are the concerns, what are the things that you're seeing with this patient from a mobility, from a musculoskeletal standpoint. There are not very many courses out there on that specifically, and my course that I'm bringing to Ireland is my attempt to bridge that gap. So it's for pelvic floor physios and neurophysios, so that they can both really kind of bridge that gap and learn from each other.
Room together. Yeah.
Exactly. And I really where my idea for that course came from was what I did for my own staff. So we had multiple lectures where I kind of talked about, they were round table lectures where I talked about the pelvic floor and I talked about bowel and bladder implications of certain diseases. And then you could just see light bulbs going off. And so then they started asking me questions and I started asking them questions. So that's really, it's getting that kind of knowledge. You don't have to become an expert in neurophysiotherapy. You don't have to, get down into the deep brain connections and what's going on with us with a stroke or MS, but knowing kind of the basics of what their musculoskeletal system is going through and what their gut is going through will really immensely help you to better understand this population.
Well, I think though, just following on from that, I think there is a place for maybe delving a little bit deeper into it, because, if your neurological system isn't happy, if your brain isn't happy, or functioning properly, nothing else is going to. So I think, with all that we're learning, I think currently in our world, there's a lot of focus on pain science and the neuroscience of education and that top down as well as the bottom up strategies. But I would imagine that's probably even more fundamentally important from a neurological insult, whether it's an acquired insult like a stroke or a TBI, or something progressive like MS. You know, just to understand, well, which part of the brain is affected and what are the implications of that. Pelvic health, musculoskeletal health, you know, the whole body is going to have a role to play. What sort of issues are you dealing with on a daily basis? Is it urinary retention? Is it constipation? Is it continence? What are you seeing day in, day out?
It runs the gamut, honestly. It really depends. And I do agree. I'm a bit of an anatomy nerd, but I realize not everybody is.
We are. All
Yes.
the cool kids are.
So I can get into the weeds on neuroanatomy and really kind of break it down. But it does depend on, you know, the disease process. So for instance, with multiple sclerosis, what we see a lot with these patients is kind of the overactive bladder. And that is because with multiple sclerosis, it's a loss of myelin. And so a lot of the nerve endings become unmyelinated. They don't send good signals to the brain. So what I find is that the overactive bladder in patients with MS has less to do with what's actually going on with the bladder and more that the patients don't trust their own signals anymore because of that loss of myelination. Okay. So I love to give this example. I had a patient that had MS for about 5 years. She had recently seen a decline in function, so she had a flare. She had relapsing remitting MS, and she was going to the bathroom up to 30 times a day. And the doctors thought she just had overactive bladder. They kept trying to put her on medication. It really wasn't doing anything, and so her therapist said, "Hey, I want her to see Carina. I want her to get an idea." And what I had found was the patient didn't feel when she had to go. So what had kind of thrown off this overactive bladder was that she was going all of the time to empty her bladder so that she didn't leak.
Just in case.
So yeah, just in case. So we talked about, she also had stopped drinking. So she wasn't drinking any water, you know, that kind of age old, if I don't put anything in, nothing will come out. And so we talked about fluid management. We talked about going kind of timed voiding. So if you don't trust your body, let's trust the time. Let's do some behavioral interventions. And she did that for 2 weeks and was completely normal after that. Had no issues. Came in for her second visit and said, "I don't need you anymore." You know, her bladder diary showed that she was going. And it was just these little, and it was me explaining to her again,
calming her down.
Yeah, knowledge is power with these patients.
Yes.
And so education goes so far. And that's why I tell people, if you're afraid of touching a neuro client, if you don't know what to do with spasticity, or you're, you know, worried about your treatment table is too high to get there from a wheelchair, doing a little bit of education with these patients can make such a huge difference. So we'll see that with spinal cord injury. I might see sometimes a flaccid bladder or a hyperreflexive bladder, depending on the level of their spinal cord injury. So sometimes we're talking more about a cathing schedule versus attempting to be able to urinate on their own again. We see a lot of constipation with all of the neurologic disorders, Parkinson's, CVA. You can get spasticity in the pelvic floor. This is a lot of physicians will see spasticity everywhere else, and they're Botoxing the legs and the arms, and then the patient tells me that they have severe pelvic pain, and sure enough, they need Botox in their pelvic floor. So it runs the gamut. But as you said at the very beginning, bowel and bladder is not high up on the neurologist's lists, because they're busy trying to manage all of these other issues. But sometimes bowel and bladder can make the biggest impact for the patient.
Well, I think, you know, when we look at the stats, we know that dementia is the #1 admission to nursing homes in the US, but, you know, continence is the second.
Yes.
And if you put those two together, you know, that neurological deterioration plus continence issues, I mean, that's just, we're talking enormous numbers of people, you know.
Exactly.
I think, you know, the role that we can play to really give people back independence, mobility, confidence, and again, just that headspace then to focus on their gross recovery. It's absolutely vital. So these are really conversations that we need to have. In terms of spinal cord injuries, you know, what are some of the scenarios that you're coming across with that population?
So there's a wide variety of things. Number one that I've done with the spinal cord population is nursing education. So often these patients, because in the initial period after their spinal cord injury, they have an areflexic bladder, and there's nothing we're going to do about that. So they need to be catheterized. However, there is a lot of research out there that it's important to take that catheter out, that indwelling catheter out early on.
Okay.
And what we were seeing is patients were in the acute stage. They were waiting for a bed in a rehab hospital to do their inpatient rehab. And so their catheter was in there for sometimes 6 to 8 weeks. And so by the time, which increases the risk of infection, increases, a host of problems. So we started with just education with the nurses. You know, we need to take that indwelling catheter out and start clean intermittent catheterization early on. We look at educating the neurotherapists about if it is an incomplete injury and there is some sacral nerve sparing, encouraging them, first of all, to not be constipated, and second of all, to try to empty their bladders if they can, and then do clean intermittent catheterization for any post-void residual that might be there. When I'm seeing them on the outpatient side, it really is a matter of constipation is a big one, especially if they are unable to be upright for long periods of time. So we get a lot of patients that are spending a lot of time in bed or in a chair. And so when you don't have that upright posture, your gut motility decreases. Often these patients are not eating well after their injuries. And so when you're constipated, then you're not going to get your bladder, to work properly either. Yeah. So we're really seeing a whole host of problems. And what I encourage therapists with working with the neuro population is it's important to travel along that continuum of care like I just illustrated. We need to be educating on the acute side. We need to be talking to our inpatient rehab therapists, and then we need to be making sure that they're seeing a pelvic floor physio on the outpatient side. And nowhere is that more evident than the spinal cord injury population.
Because again, I suppose, the thing with the spinal cord injury population is, you're going to have a mix of ages, coming through there.
It's mostly young men.
Yeah, unfortunately. And I think, you raised a really important point there, because I think one of the biggest things that we can do is to actually alert our neuro colleagues to the fact that these might be issues, and then to encourage them and show them how to screen for them, and to ask these questions. Don't just assume. Which brings me then to, do you also talk about the importance of screening or asking about sexual health with these patients?
Absolutely. Again, I think this is another kind of thing that where we can, as pelvic floor physios, can really jump in, because they're afraid to ask these questions. Whether it be a gentleman with a spinal cord injury who is worried about getting an erection or fertility, to my female patients that have MS and are anorgasmic, and often this is because of some weakness in the pelvic floor and that demyelinization, that loss of feeling. So that is one of the screening questions. So all of my neurotherapists at my center, when every patient comes in for an evaluation, they were given 5 screening questions.
Nice.
Having to do with the bowel, the bladder, and sexual health. And, I think sometimes there is a little bit of reticence on the part of neurotherapists about asking about sexual health. That's something that they're, a little bit uncomfortable. So I told them, if you don't feel comfortable talking about it face to face, you can give them the screening questionnaires on a piece of paper and then say, hey, I've got this person that would be really great to talk about this with. Yeah. But the other thing that I have often found is that because neurotherapists in particular spend so much time with their patients, I think even more than orthopedics sometimes, they're seeing these patients 3 to 4 times a week for months on end in their rehabilitative process. Patients become more comfortable with them. So my favorite story to tell about this is neurophysiotherapist who's a very good friend of mine. So she is used to all of the things that I talk about. She's not necessarily one to talk about them, but she's used to me. She was working with a woman who had recently had a stroke. And they were about 4 or 5 weeks into their therapy when she brought up the fact that she had been hyper aroused since her stroke.
Okay.
And she didn't know who to talk to. She had never mentioned it to a physician. She had never mentioned it to any of these practitioners that she had seen, but she felt comfortable with my friend Devin. And she said, you know, I don't know if there's anything to this, but I feel like it has to be connected to my stroke in some way. Because she said, I believe her quote was, "I woke up in the hospital feeling pretty fine," was kind of her quote. And so my friend Evan said, "Listen, I know who to send you to. I know who we can see, you know, send you." It indeed was, she had some spasticity, and she had some a sympathetic upregulation that was causing it, and we were able to calm that down. We were able to normalize the muscle tone, and it went away. And so, and this was, again, something she had never mentioned to any of her many pelvic health practitioners in the time that she had been seeing people. So it's a great, that screening and making people aware of there is a place to go for these patients, and don't just dismiss kind of what they're talking about, and be comfortable talking about it. I think
we forget it, don't we, that, you know, not everybody is like us. I mean, we spend
exactly
talking about sex and poop and bladder. Apparently normal people don't do that, and normal physios don't do that either, I hear, but you know.
I know.
I think that's really interesting, because I think, you know, my first thought, you know, thinking about sexual health issues with this population would be, you know, just the ergonomics of it, you know, using props and pillows. But I think you've just really illustrated beautifully, there's a whole spectrum of issues in there as well. I wonder, do you see any overlap from maybe some of the work that we see with post-prostatectomy sexual function? Like, is there a role for vacuum pumps and other devices, you know, vibration devices for men who've had some sexual, you know, really downstream effects from their injuries?
Yeah, it's definitely educating patients about why. You know, we see often in the post-prostatectomy clients, for instance, they're given this vacuum pump and they don't really know why they're supposed to have it or what they're supposed to do with it. Exactly. And it's very similar. So patients with neurologic dysfunction, depending, I'll use spinal cord injury, for instance, many of them can get physiologic erections, but can't always get psychomotor erections. So they may need to use Viagra to have an erection when they want to, you know, in order to be able to have intercourse with their partner. But fertility, then, it becomes a big concern. So that is where we can talk about vibration. We can talk about, there was a study even done on rectal electrical e-stim for helping to induce ejaculation. So I will often go over that with many of my patients. I work very closely with a great urologist who also specializes in sexual medicine. And so we talk back and forth about what may or may not work for these clients. And then honestly, as we pelvic floor physios feel comfortable talking about positioning all the time, you know, with our women with pelvic pain, it's sometimes talking about that with our neuro clients. They cannot get into every position. You know, they don't have the physical capacity to get into every position. So sometimes we're talking about that. We're talking about, you know, what position is going to encourage blood flow, what position may encourage ejaculation with these men. So there's absolutely a place for us as pelvic floor physios to talk about fertility and sexual health. Getting a team in place is really important. And so that's why, you know, I really encourage physios that are possibly getting into this population to find a urologist, even if it's not in their direct area. I have lots of clients that are willing to travel. We happen to have a great one in Columbus, but prior to him being there, we had to send people to, you know, a couple hours away. But if that's something important to them, they're going to go. And so making sure you know where those resources are. because again, they're also, most patients don't know where to find these things. So sometimes it's just you directing them to the proper resources.
Well, that's it. I mean, it's easy when you know how, when you know what the answers are, but to create a space where patients can ask these questions, because I would imagine, again, kind of similar to the post-prostatectomy men, that it's important that we do resume these housekeeping erections as soon as possible to maintain the patency of the structures. So I think getting pelvic health involved early would actually be really, really important from that perspective if they are going to regain that aspect of their lives again. So
yes, absolutely. And again, it goes back to that continuum of care. So talking to them, again, I've seen a lot of practitioners kind of laugh it off, like, oh, you had a spinal cord injury, that should be the last thing you're worried about. And it's like, well, no, that's a pretty big thing. It's not exactly, it's a quality of life issue. And so I always kind of tell people, if you don't, it's great that we saved your life, but if you don't have a quality of life to go back to, what was the point? So, I really want to make sure that if it's important to this patient, it's going to be important to me, and I'm going to try and help to find the people that I can connect them to, even if it's not me, to make sure that they can regain some of this function. So
basically what you're saying, that physio is really the answer.
Yes, it is.
If we can't fix the problem, we'll find somebody else who can for you,
And I think that's what we see. I mean, not just in this population, but in all populations, physio has become such a touch point for patients. They feel comfortable. Yeah, literally and figuratively. They feel comfortable talking to us about uncomfortable subjects. They feel comfortable asking us, and we really, because we kind of, again, no pun intended, have our hand in everything. We kind of
okay, that's quite visual.
Right? Pelvic floor physios, we have the best puns. But, we really are able to reach out to other people, and I think we feel comfortable reaching out to other physicians, other practitioners, and we really try to find the answer. I think so much in the medical community in other specialties is so siloed. So, physicians are being forced to just look at their area and not really look at the whole patient. And that's what we do. We look at the whole patient.
Absolutely. I mean, there are so many different medical specialties already living in the pelvis, from orthopedics to urologists to colorectal, pain specialists. And then you add neurology into the mix as well. And often there isn't a huge amount of communication, unfortunately, between these medical specialists. So I really think that we have a role to play as gatekeeper and developing effective communication strategies with our medical colleagues as well as with our patients. I'm going to just change tack just a little bit, because I want to give a shout out to all the work that you do on behalf of our profession. Because you don't just wear this hat, you don't just wear a clinical hat and a teaching hat, you've also got a profession leading hat on as well. What's your role in the section of women's health?
Yeah, so I am the director of programming on our board of directors. And thank you. And what that is that we have some very large conferences in the States. Probably the biggest conference that the American Physical Therapy Association puts on is something called the Combined Sections Meeting. Okay. And what that meeting is all of the different specialties in physiotherapy getting together, and we put on programming not just for our specialty, but we try to put on cross programming. So the specialties can talk to one another. So I did a talk on neuropelvic floor that attracted both neurophysios and pelvic floor physios. Yes, and I've still had people that come up to me and say, I never thought about that, or I never connected those dots. So it is my job to find speakers. We have pre-conference speakers, and so you will be speaking for us in 2019 in Washington, D.C. But we also, and then we have speeches or 2-hour talks, smaller talks throughout. So, and then in that role, I sit on the larger board of directors. So we discuss things like the name change, which I know is a hot topic within both the United States and the international. Everybody, yeah, you know, is women's. We're not just women's health physios anymore. We treat a larger population. So, so that's what our board of directors does, is really try to continue to move the specialty and the profession forward as a whole. And it's a very.
I think we've just lost you there a little bit, Carina. Hopefully we'll get you back shortly. There you go, you're back.
Sorry about that.
Okay. Well, I mean, it's a huge undertaking. So I really want to give a shout out, because, you know, if it's not for people like you giving of your time and your expertise to this, I don't think the profession would be where it is now. And also, I think the future is bright for physical therapy in the US, but, you know, hopefully globally as well. I think we are a very underrated profession. We fly under the radar quite a bit, but I think certainly the way medicine is changing, you know, we are moving more towards, whether we want to call it integrative or functional, you know, I mean, who's more functional than a physio?
Exactly. And I mean, I absolutely love my profession. You know, I'm always proud to tell people, you know, that I'm a physio, and especially with pelvic floor physio, we're gaining so much traction, and people are starting to know we're here. I point to even just the American College of Obstetrics and Gynecology recently called us out as physios for the fourth trimester.
Oh, yeah.
Yeah, we were very excited about this. So
amazing.
it's really a great time, and so that's why I really it's my passion to get physios out there and really talk about our profession and talk about our specialty.
Well, I think that's the thing, because I think as a profession we're very good at talking to each other. Maybe we could improve talking to the rest of the world a little bit as well. So
exactly. That's my goal.
Something to work on. Carina, where can people find out more about your courses, not just in Ireland, but wherever you're teaching?
So I do teach for the section on women's health. So I teach most in the States for that. If you ever have any questions, emailing me is always the best. I'll be teaching a pediatrics course in England in October. I'm teaching the neuro pelvic floor course in a couple of weeks in Ireland at the University of Limerick. So that is usually emailing me is the best way to be able to find out where I'm teaching, and also to solicit. So if you do have peds and neuro are the two topics that I teach on the most, and so if you have an interest in that, definitely contact me, and we can always work something out.
And what's the best email address to use for that, Carina?
It is my last name, so SIRACUSA, and then DPT@gmail.com.
Fantastic. Well, hopefully you're not going to be inundated with questions. And I want to thank you for, you know, you're always very gracious in answering questions within the Global Pelvic Physio Group, so we're very grateful for that as well. I would strongly encourage you to check out Carina's work, to come to her course in Ireland, come and have a weekend in Limerick.
Why not?
And you know, I'm going to be in Columbus in the autumn, so hopefully I'll get to take you out for dinner there. So thank you for coming all the way over to us here. Carina, it's been a pleasure, and thank you very much for sharing all those gems with us, and we'll see you on Facebook.
Yes, thank you so much.
All the best. Bye-bye.
Bye-bye.